said, I am not going to turn it over to Sarah Tremblay. Sarah is the Guardianship Program Manager, and she will be our facility or our presenter for today. So, Sarah, the floor is yours. Thank you.
Thank you. So I apologize in advance. I tried to get on a little bit earlier and I'm having a lot of technical difficulties as well as Anthony this morning. So I'm going to share my screen. Unfortunately, if I turn my video on, it cuts me out. So I'm not going to be on video. So I apologize for that. But thank you for having me. I am trying to see, where do I share my screen at, Anthony? Do you know? I can't find that button. Oh, I think I found it. Hold on. Can you guys see my screen?
We can.
Yeah.
Wonderful.
Yes, we can. And I'm sorry, I was talking and all muted and whatnot, but you found it, so you're good.
Perfect. All right. So, as you might see, I'm a little bit technical challenged on this, so bear with me. Please feel free to ask questions, and if you can put them in the chat, like Anthony suggested, that would be wonderful. Today's topic that we will be covering is the basics in regards to consent, capacity, pre-planning, and guardianships in the state of Washington. It's a fun topic that's very dear to my heart. I myself am a certified professional guardian for clients in Washington State. So I welcome this discussion. The first couple of things that I want to go over is just what was going to be presented today. We will go over what constitutes consent, who can provide consent in different scenarios, what is capacity, how does capacity differ from informed consent, tips for assessing client capacity, consent versus a release of information or an ROI, importance of pre-planning, different resources, and then we will go over the petitioning process under the current Uniform Guardianship Act, which is abbreviated with the UGA. So before I begin with the content, I just want to take a second and note that the Health Homes program is a joint venture between DSHS and the Healthcare Authority. And so I will be using the term Medicaid, which is meant as an umbrella term to incorporate both of those entities for the purpose of this presentation today. So with that said, let's dive in. What is consent? So consent for governmental benefits standpoint is the act of a person giving their permission to participate in and or to accept or receive a benefit of services by entering into a contractual agreement for those services. Consent is required for any services provided by Medicaid, including services provided through health homes. Consent is obtained from either the client or a person with authority to act as their decision maker on behalf of that client, when the person giving consent has the capacity to execute those authorities in order to enter a contractual agreement. Who can provide consent in Washington State? As you guys probably know, consent can be provided by any adult client who is over the age of 18, a parent of a minor under the age of 18, a client's court-appointed guardian or an agent of the court with designated authorities, a client's agent designated under a power of attorney, a client's designated authorized representative. It's important to emphasize that consent can only be obtained from an individual when the person giving the consent to enter into the contractual agreement has the actual capacity, which can sometimes be called residual capacity or cognitive ability or cognitive capacity to do so, and that they understand what it is that they are agreeing to. So let's talk a little bit more about what capacity is. Capacity is defined as the cognitive ability for an individual to A, receive information, when it's given in basic terminology about what services or options that they will be approved for. And it's their ability to process that information and all of the presented options in order to see, formulate, and express in their basic terminology, their preferences or willingness to accept those services, or if they decline those services. In Washington State, under the current guardianship statutes found in RCW 11.130.037, for an adult, adults are presumed to have legal capacity under the law until it is determined by a court of law that they do not. So in comparison and in contrast, by default, a minor under the age of majority in Washington State, that's 18 years old, is not presumed to have legal capacity under the law to knowingly enter into a binding contract. This would include providing consent for services under governmental benefits. This is why parents still consent on behalf of the minor to enroll and participate into the Health Homes program. Now, minor authorization is different for minors aged 13 through 17 who are required to authorize the release of their own treatment notes and information through a release of information process. So this is why adolescent minors between the ages of 13 and 17 must be the ones to sign their home health adolescent information sharing consent form involving the release of their information pertaining to any treatment or care involving their family planning services such as birth control and abortion, HIV/AIDS, sexually transmitted diseases, mental health, medications, services, or chemical dependency services. Additionally, this is why adolescent minors in this age group of 13 to 17 must also be the ones to sign their release of information for substance use disorders services, that SUDS form, when they are being received, when those services are received. Let's see what else. Whenever possible, those forms should be completed directly with the minor, and it is encouraged to be completed with the minor in private to avoid any undue influence from others, including parents. Carrie, how are we doing in the chat? Is there any questions so far?
Nothing so far, but when one comes up, do you want me to just butt in?
Yeah, or I'll periodically ask you.
Sounds good, Sarah.
All right. So moving along, how does the capacity then differ from informed consent? So let me back up for a second. Given the noted differences that we just talked about, at times there will be discrepancies between medical provider documentation of a client's non-decisional status and your assessment of the client's cognitive ability to consent to our Medicaid services and programs. When such discrepancies arise, it is okay to notify medical providers that consent cannot be obtained for the client, or that it can be obtained from the client based on whatever your own individual assessment of that client's cognitive status is as it pertains to their understanding and willingness to self-direct their own care. You do have the right to feel empowered in your assessment outcomes. To address why that is, let's take a minute just to discuss how capacity actually does differ from informed consent. Okay. Since healthcare providers such as hospitals, skilled nursing facilities like medical clinics, and Medicaid all serve different functions, there's different statutory authorities for client consent in order to apply for services and receive them. So RCW 7.70.065 is the informed consent statute for Washington State. This is specific to healthcare providers. This is not for DSHS or for Medicaid purposes for long-term care planning or consent services. Informed consent is specifically for who can make medical decisions for healthcare for a client who cannot make it for themselves. And it is also referred to sometimes as LNOC or legal next of kin. It's a hierarchy of who is allowed to make decisions for medical purposes only. So hospitals and healthcare providers use the informed consent statute to obtain consent for their patients for medical care and treatment. This statute allows for family members, friends, and other adults with knowledge of the patient. A lot of times you'll see like a neighbor or a pastor who's known them a long time to be able to consent on behalf of the patient for medical treatments. In saying this, it does need to be clarified that health home care coordinators and providers that also work within hospitals and clinic settings would still fall under the health home scope and follow health home policies and procedures. Okay. However, Medicaid, on the other hand, is not a healthcare provider. Instead, we are administrators to accessing Washington Medicaid's medical and long-term care services and supports. So even though our supports include healthcare providers, we act more as an insurance liaison to accessing such health services, but we ourselves are not healthcare providers. So what does that mean for Medicaid purposes? Since Medicaid is not a healthcare provider, we cannot use the informed consent statutes for obtaining our consents for our services and treatments. As such, Medicaid must follow Medicaid law when obtaining client consent for our services and supports, so we cannot use this statute. Instead, Medicaid law is outlined in CFR 42, which requires the person-centered planning process to be driven by the individual client and to ensure that the individual directs the process to the maximum extent that they are able in order to make informed decisions and choices about their care. Now, usually that's a hot topic about the difference. Is there any questions so far?
Nothing in the chat or the QA, Sarah.
Perfect. Okay, so capacity outlined in CFR 42. In order to comply with the person-centered requirements from CMS, Medicaid should look to the client directly to make their choices about which services and supports they would like in order to ensure client choice, their preferences in making final determinations for what services and supports we can provide to them. This includes the signing of all Medicaid documentation on behalf of the client. So first and foremost, we always look to the client. So what does this mean for you? This means that as long as the client can indicate that from their free choice to authorize a representative, Medicaid can accept that representative's signature on Medicaid documentation and allow the representative to make other decisions about the client's Medicaid services and supports. This would include enrollment into specialty programs such as health homes. Important to know that unless that representative is appointed in a power of attorney with the specific authorities for long-term care or governmental benefits management, it will need to be redone every year if it's done on a authorized representative form. Okay. It also means that free choice, otherwise sometimes referred to as preferences, can be expressed both verbally and in writing. Some of our clients can't write. Some of our clients can't speak. So it's important that we ensure all ways of communication and that we are honoring that client's preferences. Although whenever possible, written expression is always the preferred standard of practice, we can obtain client preferences in other ways, such as verbal consent or use of translator services. Maybe, for example, some clients use communication assistive technology devices. Some use communication boards. Those are all appropriate ways to obtain preferences and free choice from a client under the ADA, which is accommodating for Americans with disabilities. So in a nutshell, what does this all really mean? Let's recap. So Medicaid always looks for the client as the number one source of information in their consents, as permitted under the law. This is true even when there's a designated power of attorney, because a power of attorney can be challenged if the agent is not acting in the good faith of the client themselves. A POA can always be revoked. A POA can be transferred or delegated between different people or agents. And it's important because a DPOA can not be in effect at a given time that you're reviewing it. Sometimes there's a requirement for what's called a triggering event. Some of those triggering events, let me see, what examples could I give? Some include the requirement for one or two physicians to provide a statement of incapacity in order to trigger and activate the effectiveness of that power of attorney and the authorities that are granted within it. Some are set up for specifically a certain age. So automatically upon maybe, let's just say, the age of 60, if you turn 60 and that's what's written in your paperwork, it is in effect. However, just because a power of attorney is in effect, because some go in immediately upon signing the document, does not mean that the person, which is called the principal, who executed that, which would be our client, it does not mean that they do not have their continued right to make their own decisions. If they still have capacity, they are the ones that we need to obtain consent from. So capacity is residual in nature and very fluid, meaning that it can fluctuate depending on several variables and situational cues and circumstances. It can be even dependent on the type of question and decision that's required for the client. Now, this is important when you think about the difference between abilities to consent for informed consent for medical treatment or maybe a surgery or some type of procedure, which has a high threshold of risk to the client's life, versus accepting Medicaid services and supports where it's least likely to risk their life for that type of decision to be made. So the thresholds are completely different between informed consent and consent to services for long-term care Medicaid. This is why you might see that we are saying, yes, they can consent to our services, while the hospital has documented that they're non-decisional for informed consent for medical. So capacity thresholds, like I just said, vary depending on the services or treatments requiring a decision. Carrie, I'm going to ask you if there's been anything that comes
Yep,
up.
we have
Okay.
three. I was waiting for a break in your conversation here. So we've got one question from Eric. So does this mean we can get verbal consent for the consent form?
If a person has capacity, you need to look at your policies first and foremost, but legally, if a person has capacity to make a determination and it's well documented that they don't have an ability to physically sign, we could accept a verbal approval. That being said, it also depends on what the policy is, and I'm not familiar with what the policy for health homes is. Next question.
Yeah, I'm waiting for Anthony to chime in. Maybe he'll chime in about that one later. Because with our consent forms, it is documented in there. Next question, because we've got three questions from Rebecca. Sometimes we get feedback that clients cannot sign with an X, but if that is their signature, then should HCA and the MCOs accept this?
That's a very good question because there are clients who have not known how to, have not been taught how to write, but they still have the decisional capacity to make decisions. Yes, they can sign with an X. When that is done, they have to have two witnesses that are third-party witnesses stating that they know the person and that that is their signature. And it cannot be a healthcare provider. So nobody providing care can serve as a witness.
Okay, and then that kind of goes along with what Tom just asked. Is there space on the consent form to have a witness sign to confirm that the client wants to enroll?
I'm not sure what exactly your health home forms look like. Not every form has that, but where the client's signature is, where they're receiving it, a lot of times when we do document reviews through our escalation pathways for validity purposes in Washington State and in compliance with the ADA requirements, it can be written anywhere on there. It doesn't have to have a designated witness slot, but it needs to write under there. If it doesn't, it needs to have the printed name of the witness, the date they signed it, and then their signature. And it needs to be two of them.
Okay, and then Miriam bounces off of Tom with what are some examples of eligible witnesses?
Anybody over the age of 18 who is non-related to the client and who is not in a paid service receiving benefit, which means nobody who is providing care to them, nobody who is a paid caregiver. So that would be no doctors, no nurses. So family, friends, neighbors, a stranger who witnessed that it was. If they're 18, non-related, and not receiving payment for any services provided to that client, they would be eligible to serve as a witness. So I've seen it too where other residents, I wouldn't necessarily recommend this in different residential facilities, have served as witnesses.
Okay, and then Donna's asking, can a guardian have a client put in a nursing facility against their will?
That is a tricky question. Under the UGA, I'm going to cover that a little bit later, but under the UGA, there is not a provision to do that outside of the ITA, Involuntary Treatment Act process.
Okay, so Donna, Sarah's going to touch on that a little bit later in the presentation. And then we have a question from Eva. Just want to get clarification. A client can provide verbal consent to assign an authorized representative to sign the HCA health home consent forms on their behalf, even if they don't have a written form for authorized representative or POA. I think there's a few questions here for our health home team and consents.
Yeah, I was just thinking that in regards to that, because again, when we start talking about guardianship and a person who is claiming guardianship or power of attorney over a potential health home client or participant, that power of attorney or guardianship must be in place, and we must have proof of that. If we have proof of that and they have proof of it, that they are the actual guardian, then yes, they can opt the person into the program, but that there has to be proof of that actual documentation of that being the case before they can do that.
Okay. And then another question that came up, if a quadriplegic member resides in a family home Who can be an eligible witness? Family doesn't want to be involved in the care.
You may ask for a mobile notary. A mobile notary can trump the requirement for two people to sign as a witness. If there's known, maybe a pastoral service that comes to see the clients, if they have religious involvement, could serve in as a one, family friends, other residents if they have residual capacity. Those would be the ones that come to my mind in that scenario.
Okay. And then in the chat, there are a few comments. And then we just got another question. What if the client has a stamp to sign with?
That's dependent on policies. Require an actual wet signature. Some require a mark of the client. Under DPOA laws in Washington State, which is power of attorney laws, a stamp is valid, but that is policy dependent on the health home policies. So I'm going to defer that back to Anthony and Carrie's team.
Yes, and if I can just chime in on that real quick, I know that there was a situation regarding the stamp, and Carrie, you remember this as well, is that a stamp was not allowed, if I remember, as it pertained to the health home participation authorization information sharing consent form. It wasn't allowed, but again, this is something that is literally, believe it or not, under discussion right now with the state team in regards to whether or not that could be something that should be allowed.
Yeah, that's a different stamp. I think what Gabriella is referring to is the client can't physically sign the document, but they had a stamp created with their signature,
Well, then that should be acceptable, right?
and that would be accepted.
Yeah, that's acceptable. Yeah, my bad. I was thinking of a totally different stamp. My bad.
Yeah,
Carry on.
that should be accepted under the ADA accommodation.
Yes, absolutely.
If they have a documented physical disability in regards to their ability to sign. So yes, that would be a reasonable accommodation in that scenario.
Yep, and I had a client that used a signature stamp, so I totally understand, Gabriella. We have another question here. What if a member has 0 ways to communicate? Here's a specific example. Client had a brain aneurysm less than a year ago and has no way to communicate. Client's parents are the legal guardians. And then they just said that they joined in late, so if they missed the answer already, they apologize.
Well, at that point, if they cannot communicate, then it would default to the next legal decision maker. And if their parents are appointed as the guardian and we have documentation of that, then the decision would default to the guardian for consent. Okay. For the sake of time, I'm going to go ahead and move on. We can capture more questions as they come in. Okay. So let's talk about when capacity is in question. So when capacity is in question, it's best to meet with the client in person versus telephonically or virtually. There's several tips when assessing client capacity. I'm going to go over them next. Some are tips that are used in the moment, and others will require pre-planning for needed interventions based on the client's needs or functionality when you go to see them. Some of these may seem obvious, while others may not, but I'm going to go through my top tips that I have found when I have been meeting with clients in the field over the last 20 years. I hate to admit that it's been 2 decades, but okay. Before we get into the tips, realize it's important that you assess if anything medically may be occurring that could be impacting the client's cognition or their ability to focus. Some of the main topics that I have run into that may affect it would be possible infections like a UTI or pneumonia or an STI. Is their blood sugar level okay? And don't just assume that it's old age or progression of a disease process for their cognition fluctuations. Once you are able to assess for those possibilities, then these tips would come in handy when you're assessing for the client capacity. Let's dive into it. Okay, first and foremost, remove distractions when discussing information with the client. For example, it's important to turn off the TV and radio, close any curtain blinds that may be bright in their eyes or distracting with outside visuals. Ask other people to stop talking. Maybe have a nurse turn off any beeping or alarming equipment so that the client can focus on the discussion. Meet with the client at a time that's typically good for them cognitively. This would require a pre-scheduled time to meet with the client after discussing maybe with caregivers what time of day they seem to have better moments of clarity. Some are more alert and oriented in the mornings, while others may be in the evening, and some are better after meals. So that's just getting to know your client before going out and assessing that. Speak slowly, clearly, and loudly, and allow for extended processing time between your questions. Speak with the client both in the presence of others and alone to ensure that they are not being influenced to choose one service or treatment over another because of a person being present. Have the conversation with the client at eye level. If the client is sitting, you should sit. If the client is laying down, sit beside them, but don't stand over them. Doing this promotes feelings of safety and freedom for the client, and it makes them more receptive to an open discussion. Use words that the client themselves uses. This promotes understanding and participation in the discussion by the client if they understand the terms and words that are used during the conversation. So if you're saying treatment, but they're saying care, be cognitive of the fact that maybe you should change your terminology so that they are comprehending the conversation better. If the client is hard of hearing, consider using amplifying devices or maybe pre-writing out your questions in large fonts so that they can read it and process the information instead of requiring audio input when they can't hear well. If you're doing this, you will need to have the equipment that you know will work. Maybe they have an ease to talk device. Maybe they have a different type of communication board. Maybe they need access to their glasses in order to be able to participate this way. So when you get there, make sure you have their required equipment for them for that need. If the client is experiencing pain or discomfort, come back later or ask for the client to receive pain medications before you speak to them. However, this should be used with caution because, as everybody is aware, some pain medications do cause drowsiness. So it's important to ask the staff how the client would typically respond to pain medicines to ensure clarity and ability for them to participate. If you are unsure if the client understands what is being discussed, go back another time or have another person even think of meeting with them to recover the same information. It's important to see if the client is consistent with their stated preferences, even if they might not remember the prior discussion with you, and that they are consistent despite who they're discussing the same topic with. If the client has developmental disabilities or neurological deficits, maybe consider having the discussion in the presence of their favorite comfort item or person or activity. This could be in the presence of a person who is known to provide the client with comfort. It could be while doing their favorite activity, such as coloring or playing cards while having the discussion. It could be allowing the client to hold their favorite stuffed animal for comfort while they have an important discussion. Use the client's preferred communication methods when assessing their capacity. Do they prefer sign language? Do they use baby sign versus actual ASL? Do they prefer to use picture icons or a storyboard to communicate? Do they have a communication board? Do they have nonverbal methods of communication that you need to be aware of, such as maybe blinking once or twice for different responses? Do they process information better visually or in writing? Things like that need to be considered and pre-planned out and discussed maybe with caregivers who are familiar with the client. And then lastly, use in-person professional interpreters whenever possible when assessing capacity. This is extremely important because there are a lot of languages that require emphasis on facial expressions and body movements, not just in accordance with sign language. So an example I have was the Tagalog language has different dialects, all of which are very heavily influenced in body mechanics when communicating different words. So interpretation of language and questions is drastically different when using an in-person translator, when those body mechanics and visual cues can be obtained versus electronic or online or telephonic interpreters for that same language. Okay, I'm going to stop and ask if there's any questions, Carrie.
I don't see anything in there right now.
Okay. Perfect. So we're going to talk about release of information. Although a minor's treatment and services typically fall under benefits managed by a parent or legal guardian, adolescent minors between the ages of 13 to 17 do have civil rights pertaining to their care. Those rights include, but are not limited to, an adolescent minor between the ages of 13 to 17 must be willing and voluntary to participate in treatment or services, even if said treatment or services was consented to by the parent, guardian, or person with their designated authority. And they are permitted to control who has access to their records. This means they have the civil right to access, maintain, and authorize the release of any of their protected health information. Specifically, for this age range, 13 to 17, they maintain their right to release their information about their care, treatment, medication, services to anybody through the release of information process. So, as you can imagine, this can be very difficult when a client is the child who is consented into services who are voluntary, but they don't want to disclose it to their parent who is consenting to the services. By law, they do not have to require that. This means that when working with families or adolescent minors in this age group between 13 and 17 years old, the adolescent minor must sign their own release of information forms unless a court order indicates otherwise that somebody else has authority to do so. Is that posing any questions, Carrie?
Not right now.
Perfect.
Oh,
Nope.
how
Okay.
just got one. Carly just sent one. How about a 13-year-old that has a higher violent behaviors and on holds?
They still have a civil right while they are on a civil hold. So they are able to still sign their own release of information forms. Unless a court order specifies otherwise through ITA court, typically they don't do that. That would be a guardianship court through probate guardianship law. It's a different court system.
Okay, and then we got another question from Gabriella. For medical procedures, can the adolescent give consent or just have the right to agree or disagree to the procedure?
Both. Both. They can sign the consent and they will be the ones who have to say whether or not they want it. However, if they are under the age of 18 and it's a medical informed consent, the parent can still consent to the service. It'll be up to the individual treatment provider to determine whether or not they will proceed with the procedure or treatment if the client is opposing it.
Okay, and then we have a quick question from John. What if the minor is mentally, cognitively impaired?
Well, have they received a guardianship for that client yet? And if not, that client can always say whether or not they would like a family member's help. They might not know to say sign consents, but they could say, I want my mom's help, or who do you want to help you? And they can point to that person. Um, so it's very situational, and those would be recommended to be discussed with supervisors. The family may need to get guardianship in those scenarios. Any other questions, Carrie?
I think we're caught up for now.
All right. Well, that's a great segue into guardianships in Washington State and what guardianship looks like. So, since January 1st of 2022, Washington State adopted what is known as the UGA. The UGA stands for Uniform Guardianship, Conservatorship, and Other Protective Arrangements Act. It adopted this in 2022 in order to assist with standardization efforts between all 50 states as the legal processes for appointing guardians and conservators when individuals need assistance with decision-making and informed consent. Guardianship and conservatorship should be done as a last resort when no other alternative arrangements can be carried out through pre-planning efforts. This is because guardianship and conservatorship is the actual legal process to restrict and remove a client's civil rights. So we're going to start with the least restrictive because under the law, Washington State requires consideration of less restrictive options to guardianship and conservatorship. So with that being said, because nobody wants their civil rights to be removed and taken away from them, everybody has a voice and preferences should be honored. So it's important that we have discussions for pre-planning purposes to avoid the need for a guardianship or conservatorship in our futures. It's extremely important to think ahead and encourage our clients to pre-plan to ensure that their choice is honored even after they can no longer participate or self-direct their own care. As care and service providers, you should be encouraging and assisting your clients with exploring pre-planning alternatives to ensure that their voice will be heard later on as well as now, and that their choices will be honored indefinitely, especially when they're unable to verbalize that any longer or self-direct their care for themselves. You may be wondering, what is pre-planning then, and how do I do that? That's exactly what I'm going to be discussing next.
Hey,
So,
Sarah, before
yeah,
you move on, Anna has a comment and a question, and maybe you'll touch on this. Many of the families do not have the money to get an attorney or a guardianship. Are there any resources? And then she says, I have asked them to ask attorney for pro bono services to help them cover the financial aspect of this. I'm not sure if you'll touch on resources or not, but I wanted to make sure we got Anna's comment out there.
I'm going to put a pin in that one if you remind me at the end for that, Carrie, because I do go over that a little bit.
Okay, Anna, you're gonna have to help me remember. Thank you.
All right. So the main alternatives to guardianship and conservatorship in the state of Washington are designated powers of attorney, That can be for healthcare, which is often for the person. That would be authorizing long-term care services and supports, different service programs, such as health homes. And then there is of estate or finances that involves anything related to money, banking, personal property, stocks, bonds, anything that is a financial resource. It could be advanced directives, mental health advanced directives, living wills, authorized representative or AREP forms, or custody agreements. So these listed estate planning documents are the most common alternatives to guardianship and conservatorships in Washington State.
And you got a question from Gina. How
Okay.
can someone contest their conservatorship? And then we got another question too.
I'm going to save these questions till the end. I'm going to write them down real quick because I think it'll be answered in most of the order of this. So contested.
Yep, I wrote them down too, Sarah. Okay.
So these predetermined conditions in these legal documents provide a way for upholding the client choice. So in each of these, I'm going to go through this. So an executed advance directive may include different directions to how a client would like to receive services in certain circumstances. That allows them to also designate a healthcare agent as a power of attorney for healthcare related services and topic decisions. It does not necessarily include healthcare that encompasses long-term care services. That has to be a separate designated authority in the document. Otherwise, it's strictly for medical purposes. Same with living wills. My concern with the use of authorized representative forms, an AREP form, that it is time limited, meaning all of these other documents can be indefinite. They're ongoing until a certain action occurs. An authorized representative form is only good for the benefit period or until another assessment is required. Every time an assessment is required, or every time a consent is required, a new authorized representative form would need to be done. So if a person has a condition, let's just say dementia, for example, where we know the progression of that disease process is going to result in deteriorated cognitive status, cognitive ability of our client, to the point that they're no longer going to know who the other people are in order to appoint them and say, yes, it's fine, they can help me. We're going to be where we can't have a decision maker. So if anytime a client has the ability to sign an authorized representative form, if they don't have a power of attorney, it's very important that we encourage them and maybe provide resources for that, because when they are no longer able to appoint an AREP, that power of attorney could go into effect. I hope that makes sense. Everybody good? Okay. So why I like these is it makes client preferences for alternative decision makers known. A lot of times in some of these documents, it will show if a guardianship is required or a conservator is required in the future. This is who the client would like to be appointed. So it'll always show preferences to courts if that's needed, to medical providers. For us as Medicaid, it tells us under certain provisions when a certain person can authorize treatments or contracts on the client's behalf. Okay, how can you help with the importance of pre-planning? Okay, normalize the conversation with your clients. Normalizing the conversation is the easiest and most effective way that you can help your clients with pre-planning. Although nobody wants to think about the what ifs, these scenarios happen. We are in unique positions in our jobs to help normalize these difficult discussions and to provide resources. So normalize the discussions by making it a part of your visits and assessments with your clients and empowering them to make a difference in pre-planning their decisions. You can encourage your clients to think about supports to give their wishes a voice. So start small in ways to plant the seed in order to get clients starting to think about things. Since many times we are our clients' advocates, resource navigators, or dare I say their confidant in some cases, we are in a unique position to not only initiate these conversations, but encouraging our clients to think about and execute plans that could ensure that their opinions matter in the future. Okay, don't wait until a cognitive decline or memory impairment starts in order to have these conversations. By then, it's too late. By the time that you notice a decline, your client's executive reasoning may be impaired, which will impact their ability to make the best decision or most educated, informed decisions for themselves about these life decision choices. So the biggest mistake that I see is when providers or caregivers or our staff have been working with a client, especially like in the case of a person with dementia or who has had a stroke, where their provider has documented a steady decline over the past several months to years, yet has never initiated these discussions prior to the part of them losing their ability to participate in these discussions. Provide resources. I provide a whole bunch of resources next. You will have this slide deck sent to you with these links, so please feel free to use them. Don't feel like you have to write them off the screen or take a screenshot. Okay, so some of the most friendly resources that I know, and to answer the question about where you could go for these services, Dementia Estate Planning Toolbox is a great resource, even if the person does not have dementia. They have a great power of attorney template forms that includes Medicaid governmental benefits clauses to cover any type of Medicaid services on behalf of the client. That can also be found at the Washington Law Help website. It was revised in June of 2024 to include any type of governmental benefits management. That way, if the client no longer is able to in the future consent to any of our services, the agent who is appointed would be able to do that on their behalf. Another good resource is the Dementia Active Collaborative. Some other pro bono counsel services would be the Pro Bono Legal Counsel, Northwest Justice Project, or the Washington Law Help programs. They have some for low-income clients. So anybody who has a client on Medicaid services would be eligible for any of these services. These resources have an exception for Medicaid clients. So if you're filing a guardianship in the state of Washington, on the petition portion, there is a checkbox to say whether or not they meet Medicaid state benefits eligibility. If that is checked, the court waives the filing fees and the costs are appointed to be paid through the county expense, not the client or family's expense. The only caveat to that is if the client's family or say a facility that's petitioning decides to obtain their own attorney, if it's not one of these that provide pro bono services, the family or facility would be liable for those costs for that attorney. Another good thing would be to refer them to the Washington State Guardianship portal. You can find professional guardians anywhere within the state. You can filter that to a specific area or statewide, and you can actually do a form where you can request a statewide email blast with a redacted summary of the client to all guardians in the state of Washington to see if somebody is willing or able to take that case. And that's in times when we don't have an identified family member or friend who's willing to serve for the client. Another good resource would be the court clerks for the county that the client resides in. If somebody wants to, they don't have to have an attorney to file for guardianship or conservatorship. A family member or any interested party, including a facility, like a maybe adult family home owner, could go and file a petition on behalf of saying they need a guardian. They can go to the court clerk, and the court clerk can give them the packet for all required forms, and they can walk them through that process. Okay. Here are some more resources that are often utilized. Let's see, the ADRC, the Aging and Disability Resource Center, they have specifically tailored services. If you are dealing with somebody with developmental disabilities, services through Pierce County Coalition for Developmental Disabilities, or PC2, is very, very helpful. They have a website that is very inclusive to different services, including guardianship or people willing to serve as agents for a power of attorney for those who might still have capacity to execute one, but don't have a family member or friend who would be willing to serve it. Harry, any questions coming in?
Yep, I've got 5 questions well, 4 questions and a comment for you. You just tell me when you're ready.
I'm ready. Let's go.
Okay, so we're gonna go back. Well, we answered Gina's question, so we can check that off the list. We have, sorry, that was Anna's. Sorry, Anna. So Gina's question again, how can someone contest their conservatorship?
Okay, that's going to come in this next section. So next question.
Okay, Sally's asking, is there a power of attorney form that is just for medical? The forms I find online also include financial power of attorney.
So I would recommend looking at the ones for Washington, at Washington Law Help. They have revised ones that are for June 2024. It'll always include both. Both do not have to be executed. So there's 2 separate forms on that one. One is specifically for financial, the other is specifically for healthcare. But the healthcare one encompasses a clause for Medicaid services. So that is one I strongly recommend.
Okay, and Debbie's asking, can we get some links for that information?
Those are on, yes, they are coming in, they will come to the packet.
Okay, and then she's also asking to clarify, a POA cannot put a member in an adult family home against their will.
That is correct.
Okay. And then from Suzanne, we've got, since we are required to provide education on advanced directives annually for our health home clients, can you share online training or presentation material specifically on advanced directives?
I don't know the answer to that. Are you asking if there's some to provide, or if that can be the way to do the training?
Suzanne, do you want to clarify for us in the chat? Okay, so while we're waiting for a response in the chat, oh, is this information presented suffices as annual directive education? I'm good. Oh, there's a conversation going on about ADs in the chat, Anthony.
Yes,
That-
yeah, advanced directives are only required within the first year of them opting into the program to have that discussion. Of course, if you want to incorporate that after that, that's fine. But the requirement is that within the first 365 days that they opt into the health home program, that a discussion regarding advanced directives has occurred with the client. It's not a requirement to do once a year.
Okay, next question we have from Heather. Are you going to cover alternatives to guardianship? Do you also have resources on how to find a professional rep payee and any information on this process? We have had difficulties working with Social Security and payees to navigate both voluntary and involuntary payee requests.
So the only resource I would have for that is you can Google Washington State fiduciaries instead of rep payee. And it will pull up people who are authorized as VA fiduciaries as well as Social Security rep payees. Sometimes it's good to know the actual terminology that needs to be used. So use the term fiduciary when doing a Google search. And then the other one is we utilize the Social Security website, and it's tedious, but there is no other resource other than the Google search that I am aware of.
Okay, and then Heather had a comment. Often the issue with filing for guardianship is someone willing to pay the filing fees.
So like I said a minute ago, it's important to notify the client or who would be willing to file if that's their response, to let them know there's a spot on the form that any Medicaid receiving client can have all of those fees waived and paid by the county. So there would be no expense to them for bringing that petition to file.
And then we've got a few more questions here. Can you give us examples of what DPOA healthcare can do and cannot do?
I cannot, because they are specific to the actual form and what authorities is granted in each one. Every one is different. Typically, the standard boilerplate ones that you find online, unless they have a caveat that says governmental benefits or consent to long-term care services or long-term care, do not encompass anything other than informed consent, which would be medical treatments and services. That's not Medicaid services. If there is a caveat that's set in language that states can manage governmental benefits, that would include VA, it would include Medicare, Medicaid, Social Security.
Okay. What is a mental health directive? Can POA healthcare manage the client's mental health too, or does mental health require a separate form?
Okay, great question. Again, it's all in the language of the executed power of attorney. If a client who is known to have mental health treatment and diagnoses wants to delegate those services when a certain thing occurs, maybe when their psychiatrist says that they need assistance, let's say, they can put in a term and a clause in the regular power of attorney for healthcare that gives that agent the authority to make the decisions when needed. It cannot be included by itself unless it's in the mental health advanced directive. They can be done by the same person, or it can be combined in a power of attorney without a mental health advanced directive, as long as the same terms are put in the power of attorney. A lot of times you will see just a mental health power of attorney or mental health advanced directive and no power of attorney. The advanced directive outlines what they want, not necessarily who could provide consent. So those are distinctions that are very important to know. Power of attorney has the consenting ability and has ability to make decisions. Whereas a healthcare advance directive usually just says, if I am acting in such a way, or if I have two physicians that say I am requiring treatment, I consent then at this time if I'm unable to for psychiatric admission. So they are allowing themselves to consent in advance by doing the advance directive for mental health treatment versus allowing another agent as a power of attorney to be able to consent on their behalf.
Okay, and then to go along with that, Eva's part 2, can a POA decline recommendation for involuntary mental health treatment?
No. Involuntary Treatment Act is a legal procedure through the state of Washington that it trumps guardianships, power of attorney, and individual consent. It's involuntary, meaning nobody can consent to it. It's done because you're a danger to self, others, or gravely disabled.
And then Araceli is asking just for clarification, when a client turns 18 and the parent needs to get legal guardianship, where should they be directed?
That's a very good question. So typically, it used to be you had to turn 18. We just did some law revisions to say 120 days prior to somebody turning the age of 18, you can petition on their behalf. So you would go to the court clerk where they reside, and you could file an adult guardianship, knowing that they're turning 18 within the next 120 days. So it's the same process for an adult.
Okay, and then the last question or comment that I'm seeing in the chat is from Anna, and it's about advance directives. Advance directive doesn't go in effect until a member can no longer verbalize or in a coma, correct?
It depends on the triggering event that's stated in the document, but typically it's when they can no longer participate in the discussion. This is their known wishes in certain circumstances. So sometimes it says, if I'm in a coma, I would like this. There's also ones that say all of the treatment, and if it's for a female of reproductive years, if they were found to be pregnant, even though these were my wishes, I would not want any of that done for me until the completion of my pregnancy. So it completely depends on the circumstance and what is the triggering event that's listed in the document.
Okay, I think we're caught up right now, Sarah.
Okay, so the adoption of the UGA has had significant impacts on guardianship in Washington. We're going to discuss what the major changes have been, and then kind of go into what the process is for filing and maintaining a guardianship. And that would go into contesting it as well. I'm going to speed through just in the respects of time. So historically, the RCWs have changed. We are now RCW 11.130 for all guardianships. That encompasses minor guardianships as well as adult guardianships. It's a combined statute now. Used to be separate based on age. Another important fact to point out here is that although it's under the same statute, minor guardianships are done on the family law dockets, whereas adult guardianships are heard under the guardianship and probate dockets in different court systems. What used to be called the respondent is now called the individual subject to guardianship or conservatorship. This is usually our clients. What used to be called the AGL or guardian ad litem is now referred to as the court visitor. There are some instances where a guardian ad litem for minors can still be referenced. used to be able to file a petition before identifying somebody willing to serve as the guardian or conservator. Now that is not the case. You must identify somebody prior to being able to file the paperwork with the court, or it will be rejected within 10 days. The guardian of person is now called just the guardian. This is the person who usually makes healthcare decisions and anything in regards to placement. What used to be called the guardian of estate is now called the conservator. This deals with anything regarding finances, property, anything that can be liquefied as an asset for the client. We used to be required to designate a standby guardian if anything were to happen to the regular guardian. This is no longer required. It's recommended, but not required. The court used to allow guardians to bill for travel times for monthly visits. That is no longer allowed. So we are seeing a lot more people who are not willing to take clients that require a lot of travel time because they are no longer being compensated to that. So we are seeing more resistance of cases being accepted by professional guardians. Notice used to only be required for interested parties identified by a guardian ad litem at the time. Now all family members must be notified whether they are estranged or not. So as you can imagine, that has significant time constraints that are required after the court hearing is filed. Okay. A guardian ad litem used to be able to be granted different additional authorities. Now we see emergency guardianships, and they're done for specific purposes and for a limited time. These people are called special agents. The court visitor can also simultaneously serve as special agent, but mostly it's usually the person who is nominated to serve as the permanent guardian or conservator will serve in an interim capacity while the investigation is going on with the court. And it's for specific purposes, such as closing bank account at BECU. And it's only good for 120 days maximum. It can also be used for transitional planning, consenting to government services on behalf of the client. Whatever the court orders for that specific person is the authority limited to that special agent. Okay, now I'm going to briefly go over the petitioning process. This is how a guardianship or conservatorship process is actually established in the state of Washington. And then once it's established, we'll go over how it's monitored and maintained. And that is when a person can contest their conservatorship or guardianship. So this is a very oversimplified visual depiction of the guardianship conservatorship process, but it starts in the blue where a client is determined that they can no longer participate and consent for themselves and that they're going to need a decision maker because nobody is with authority to make decisions for them. A person or agency willing to serve as the guardian or conservator for the client is identified and nominated in the filing petition, the paperwork for the forms for the court that can be found at the court clerk's office. The petition paperwork is completed and filed by that person in the court in the county where the client resides. Then a court visitor, which is known as a CV or a guardian ad litem for minors, is assigned to the case. Their role is to investigate whether or not a guardianship or conservatorship is needed and what limits need to be put on that, if any. And they recommend to the court who would be the ideal person to serve as the agent for this client. It might be the person who's nominated. It might be somebody completely different. The court visitor then does their investigation, makes their report to the court, and then the final hearing is held on the matter. That's the gray circle. The hearing is held and it will either result in the appointment of the guardian or conservator, the dismissal of the case saying the court doesn't find that the client needs somebody, or it might be continued to another hearing date. If it is granted, it's appointed, the letters of office and orders which state all of the authorities of the guardian and conservator are issued by the courts. Each one is different. Not every guardianship has the same authorities. So it's very important that you read the documents. And when you guys are confirming that a guardianship exists, we not only need the orders, but you need the letter of office because that states when it is in effect. It states the expiration date. Okay. So maintaining guardianships and conservatorships, again, very basic, but in blue, guardianship, conservatorship must adhere to the court orders and work within the scopes that they are actually ordered based on the authorities that the court granted. The guardian or conservator has to prepare an initial care plan and a budget within 90 days of their appointment and file that with the court. And then we go to the green circle, which is the initial review hearing, where the court approves or denies the report of the guardian and the budget. And they establish how often the court needs to review this case. If it has a lot of finances, usually it's done on a yearly basis. If it's a pretty standard, just normal Social Security client, and they don't have a lot of assets, then they typically do every 3 years. You have to obtain the updated orders and letters in correspondence with your expiration time. So if you are appointed every year and you have to come back, then every year you need to get those. If it's every 3 years, then every 3 years you would need to get both of those. Every review hearing, the client and the guardian need to consider if the continuation is required. So a lot of times a person would have a conservator appointed in the beginning, but maybe all of the court required was that a bank account be closed and the guardian be established as a rep payee. Then that conservatorship can be terminated or modified to say it's not needed any longer, and that part gets dropped. At any time, a client can petition the court to ask for a modification or termination of either the guardianship or the conservatorship, at which point a court visitor would be reappointed to investigate if the client can make those decisions for themselves. Maybe they've had regained capacity after a stroke. They no longer need it. They could authorize, the court could authorize the dismissal of that guardian or conservator. So if the client wants to terminate any portion of it or modify it, maybe they need the guardian because they don't understand all the medical stuff, but they're good with their finances. They could just have a guardian and the court could terminate the conservator, and vice versa. Maybe they are not good with money, but they can now make their medical decisions. Then the guardianship could be terminated. So to answer the question, how can you contest it? If you contest it after appointment, it's just by filing a motion to have a hearing to ask for modification or termination. And if you're trying to contest any portion of that during the initial investigation portion, it will be noted by the court visitor, and the county has to designate the client with an attorney to represent them at county expense. And then they would go to a contested docket and they can ask for a jury trial, or they can have a bench trial with just the judge to plead their case of why they don't believe they need one. Okay.
Gina's asking who files that, Sarah.
The client would have to file that, or the guardian could file it on behalf of the client. And a lot of times that does happen. And a guardian is required by the state of Washington to look at the least restrictive option possible. So if they believe that their client is saying they want something to be modified, they have to bring it to the court for consideration.
Okay, and before you leave this slide, John's asking about the yellow circle. Is
Mhm.
this person a government employee?
Who is receiving the letters? Or so when you're told that you have a client under guardianship, you're going to need to ask for their letters and orders to verify that. So the letters, an order by the court outlines every authority that that agent has over the client. The letters of office are what activate those authorities in the order. So you have to have both. You can't just have one. So if somebody says, I'm the guardian for your client, I'm going to say to them, I need a copy of your orders and letters to verify that. So typically that yellow is actually the guardian needs to and conservator need to obtain that for their records, but we need to obtain that as well if they are the ones making the decisions for our clients. You would receive that from the actual guardian. In this one, it's saying they're getting it from the court clerk.
I think we're good.
We're done at 1:30 or 10:30, correct?
I'm sorry. Yes, no, it goes to 11 actually.
Oh,
But
okay.
you have as you have much time as you need.
Okay. So after the actual petition is filed with the court, the average time for a final hearing is 4 to 6 months. If everything goes smoothly and it's not contested by the client or any other person, such as a family member, it typically will be heard between 4 to 6 months and somebody will be appointed. In that interim, it is okay for a special agent or emergency guardian or conservator to be appointed in order to make ongoing decisions until the final hearing is held. So let's talk about the average costs. Okay. Depending on many variables, including attorney fees and filing fees, administrative court fees, such as if a jury trial for a contested matter is done, it can cost anywhere from $10,000 to $30,000 for a guardianship case to be established. In just one moment, because I am going to cough and I'm going to go off. I apologize for that. I had a coughing fit and I didn't want you guys to have to hear that. So anytime a case where a client is actively receiving Medicaid benefits is filed, that cost is done by county expense. That means that the client does not pay, nor does the family pay for the filing fees or any legal service that's assigned by the court, except for if the person filing it obtains their own legal counsel. That fee is excluded from payment by the county. This is another reason why it's imperative that we do ongoing cognitive capacity assessments with our clients and emphasize the importance for completing alternatives such as power of attorneys or other advanced directives, because it helps us avoid these long drawn out expensive processes, in addition to not restricting their civil rights. Okay, so this slide I put on here because it helps us to realize the costs of executing a power of attorney versus not doing it in the long run, having to do a guardianship through the legal process or a conservatorship. Power of attorneys with a notary service, if you have to do a mobile notary, are typically between $30 to $150, depending on the miles the notary needs to drive, versus a legal process for appointment of a conservator or guardianship, which is between $10 to $30,000 per case. So it's a good visual depiction between chump change in comparison to significant piles of money, where as the county expense, all of us as taxpayers are assisting with those establishments. So it's good to emphasize the need to explore alternatives with our clients. I know it's not required annually. I make it a part of my assessments. It's a good practice, I think, but health homes, like Anthony stated, it's only required to discuss it within the first so many days. Can't remember what he said.
365.
Perfect. 365, first year. So the last thing I want to cover today is just some of the most challenging restrictions and limitations that guardians have in caring for our clients. So this was one of the questions earlier about can they do certain things? So under the law in Washington state, while a guardian or conservator can be a solution to a problem, they are not the solve-all solution for our clients. This is because there are a number of legal restrictions and limitations that govern the way that a guardian and conservator can approach certain care-related issues. And I'm going to go over the top 3 next that are usually very pertinent to us in our role here at Medicaid. Okay. So, some restrictions in decision-making are that under the law, a guardian is required to use substituted judgment decision-making model. They are only allowed to use the best interest decision-making model whenever a client's preferences are not known or able to be ascertained. That means if a client has made their preferences known by any means, especially historically over time, even if the guardian is not in agreement with these decisions, I want to emphasize, the guardian must honor that client's decisions. So even if that decision is to not be in agreement with a medical treatment or care recommendations of the client's care team, and say, prime example, a client with diabetes has historically refused an amputation of their foot after diabetic neuropathy and a wound that was not healing, and it was causing gangrene and a sepsis infection. Even though that guardian would believe it's in the best interest to authorize that foot amputation, under the law, they are not eligible to do so because the client has expressed their opinion on that matter previously to decline that service. The guardian must substitute the decision-making based on what the client would have done for themselves when they had the capacity to execute decision-making. If it's not known what their preference is, they can then act in the best interest model and say, yeah, I'm going to act on preserving the life and we're going to authorize that amputation. That being said, they can go back to the court and say, the client has historically said this. I believe the best interest would be this. It's opposing of what the client's preferences are. I need the court to give instruction. So the court could come back and still authorize something against the client's will and put it in a court order for the guardian to consent to. That is acceptable, but you have to have it in a court order. So this is contradictory to the medical model of do no harm, which emphasizes the best interest. So you will see a lot of pushback between hospitals or even us saying, they need this service or they need this procedure or surgery, but the guardian will not authorize it. It's not that the guardian might not agree with you or the provider, but it's that they do not have grounds to override the client's expressed historical preferences on the matter. Okay. Next one that comes to play is psychiatric treatment. A guardian cannot consent to psychiatric treatment against a client's will. This can only be done through the Involuntary Treatment Act. A guardian cannot consent to inpatient psychiatric treatment on behalf of the client if the client does not accept that treatment voluntarily. Now, they can sign the consent if the client's willing to go, but if the client is not, they cannot force them to go to that treatment unless there is an Involuntary Treatment Act, then the client can, by court order, be required to go there. But those are two separate court order systems. They are not consistent with the guardianship. And then finally, placement. Placement, a guardian nor a power of attorney can consent to placement of a client against that client's will, even in a court order. There is a caveat under the Uniform Guardianship Act where a court can give instruction to do so outside of the ITA process. However, what we're seeing is, even though the court is ordering that the guardian can consent to that, such as secure dementia placement, that's a prime example. They may say, yes, you can consent for them to go there. The facility is not required to accept that, especially knowing that the client is expressing that they don't want to go. So that is up then to the discretion of the accepting facility or providers. That is not something that we have discretion to say. We have to honor, as Medicaid providers, honor a court order. But just because somebody is appointed as a guardian or conservator does not mean they automatically have the ability to do placements against the client's will. And just because a court order is granted that issues such authority does not mean that feasibly it can really be enacted in practicality of finding a willing facility or provider to provide care against the client's will. I know that probably stemmed a lot of questions, so I'm going to open that up, Carrie. What we got?
I don't see too many questions coming in, but we do have one from Eva. So when the court visitor and the guardian ad litem meets with the client and other parties, will that meeting include those family members who client refuses them to participate in their health?
That person has what's called blanket authority to investigate the need for it. So even if they've been estranged and the client denies their family access, it will be limited in their scope, but they will talk to every family member to get a background about that client and the situation. And they will also investigate, even if the client doesn't say their sister, they haven't talked to them, they've been estranged for 10 years. Maybe because there's been some substance abuse issues that have occurred that have made an estrangement, say. If that guardian, or if the sister is willing to serve as guardian and has the best interest of her brother at heart, and the court visitor believes that that would be a good match, they would tell the court all of the background, all of the contingencies about the estrangement and circumstances, and they would have to justify why they would recommend that person against the client's will. But yes, they would have to talk to everybody, even whether or not the client agreed to that. They have ability like APS to investigate all parties.
So Sarah, I have a clarification from my old teammate, John. So earlier, back on slide 57, the yellow circle, court visitor, is this person a government employee? And maybe I wasn't clear and asking, so John, I'm sorry. My previous
No.
question was, is the court visitor a government official?
No. A court visitor is a person who is assigned from a court registry in rotation to, so it's on randomly assigned to each case. Unless maybe there's like a language barrier where somebody speaks that language, they would go to that um, court visitor. But the court visitor is a non-biased third party appointed by the court to serve as an investigator as to the need of the guardianship, conservatorship, and who would be best serving that client. It is not a government aid person. It can't, like myself, I have a position with the government. I also am a certified court visitor. You have to go through a training to do it. I have recused myself because most of our clients come through this, so I no longer serve that capacity. So you can be, but it is not typically. It's somebody who's been specialized in training for the investigation portions. And then they have to be appointed by the courts and certified to serve in that capacity.
I don't see any other questions coming in, Sarah. And John says thank you. So I fixed my problem. Thanks, John.
So, it's just up for questions. Anything that you guys have, throw it on out. Okay, I wanted just to clarify one point that I made earlier is the fact that, I think it was Eva, where contesting either a guardianship or conservatorship, if it's before the initial appointment of one, and it's just when the petition has been filed, then the person would tell the court visitor they don't want this, or they don't want this person who was nominated, and the court visitor will get the court to assign legal counsel, an attorney for that client. That is how that part is contested. If they want to contest it after one has already been appointed by the courts, they would have to file a motion or ask the guardian or conservator to file the motion for a court to hear their request to modify or terminate it. And then the same process would start. A new court visitor would be appointed to investigate that.
You got a couple questions that popped up, Sarah. Yeah, one from Audra, and she's saying, I think this was covered, but I can't find it. If we suspect that a DPOA does not have good intentions, who would we contact?
So there is a provision under the Uniform Power of Attorney Act, which is 11.125, where we do not have to honor it in those circumstances, as we can justify in a documentation note why we are not honoring it. So if you believe they're financially exploiting something, or they're not accepting care because it would bring somebody into the house maybe where some illegal activity is happening, and they want to minimize that, even though it's in the best interest of the client to receive those services. You could report that to APS, and then because you have that, you could elect not to honor that power of attorney until the APS investigation occurs.
Okay. And then we have a few more. Audra says, thank you. So from Cindy, if you're petitioning on your own, do all the court forms on the Washington Court's website get filled out at once, or is there a process to when you need to submit each one?
There's an initial petitioning packet that you can obtain from any court clerk. That is going to be the easiest answer for anybody to do. Yes, you have to do different steps at different times. The court gives a lot of leniency if you don't bring the correct form as a lay or unprofessional person. So they may say, you didn't have this form, let's fill it out here at the docket. They'll give you leniency if you don't provide all of them. The initial packet is what gets it started. Then after that, it's usually the court visitor and or their attorney, if one gets appointed, that will file the rest of the motions. You just have to be present as the petitioner at every scheduled hearing.
Okay, we've got a question from Anna. Is it the same paperwork for members who are almost 18 versus members who are already over 18?
Almost 18 within 120 days of their 18th birthday is the same as over 18 already. So that would be the adult paperwork.
And Melissa has a comment question. A client of mine is looking for help with her son with autism for when she can no longer care for him. I was thinking of seeing if he can get support from DDA. Would a power of attorney or a guardian be appropriate in this situation?
Is there like another family member who would be willing to serve in that capacity? If there was, then I would always do the less restrictive, which would be a power of attorney. That's depending on his level of cognition. I don't know what it is. Like, for example, I will share that my son is also on the spectrum and he will be turning 18 here shortly. And we are in discussions of executing a power of attorney for different elements, as well as what's called a supported decision-making agreement, because my son has different capabilities of learning and processing information in different ways. And I know what his preferences are. He likes storyboards with certain characters, so I can have information developed into a storyboard with those characters for him to be able to make appropriate decisions for himself. So there's all different types of resources. I would encourage that family member to go and talk with one of the, I don't know if they're in Pierce County, but Pierce County Developmental Disabilities Coalition, PC2, has a lot of resources for that to support in those kind of situations.
Yeah, and the response is that there's no other family member available.
Okay, so the mom is assisting him now, but she doesn't know when she is unable to, who would serve. Yeah, so what I would recommend would be maybe there's a thing called what's called a shadow guardian and a shadow conservator, or co-guardians and co-conservator, meaning the mom could serve in that capacity now with a professional, and the professional can make decisions when the mom is not available or when the mom is no longer able to serve. They would serve as the primary.
Okay. And just an FYI, May is putting some really good comments in the chat from some experiences that she's had. Last question that I see is from Cindy. 13-year-olds are able to consent for themselves. What options do parents have if they feel the 13-year-old is not cognitively capable to make important medical decisions for themselves?
The parent would need to take a legal action with the court to obtain either guardianship, or if they are a power of attorney, under the Power of Attorney Act, they can petition the court for instructions and the court will issue an order whether or not they believe the child should be able to maintain that, or if the authority should be delegated to the parent. As a program under Medicaid, we honor court orders.
I don't see any other questions right now, Sarah. Oh, Cindy popped up. If I understand correctly, A POA is for the individual to assign a person to act on their behalf. But what if this individual does not have the capacity to make this choice? Would the POA be valid?
No. Then a guardianship would be required. If the person does not have capacity to execute a power of attorney, the only other option is a guardianship. So in that case, they would need to file, if it's 13, file for a guardianship of a minor.
I don't see anything right now, Sarah.
All right, well, thank you so much for having me. I appreciate the time. Sorry you weren't able to see my face today.